My name is Bob Strong. I'm the Associate Provost at Washington Lee University and the Director of the Johnson Program on Leadership and Integrity. Part of Mr. Johnson's generous gift to Washington and Lee is a new speaker fund that began last year, is continuing this year, and is going to grow in the years ahead. Tonight, we're introducing the Woodrow Wilson Visiting Fellow at Washington and Lee, who is also the lead-off speaker in a series that we are calling State of the Union. We stole that from the Constitution, not from CNN. The idea is an obvious one, to bring public policy experts to Lexington to talk about issues that are important to this community and to the nation as a whole. The second speaker in the series will be here next week. Her name is Sharon Brownlee. She is a senior analyst with the Carnegie Endowment for International Peace. She's an expert on Iran. She's written about nuclear proliferation. And her topic for next Wednesday in this room at this hour will be Obama's nuclear agenda. There's actually a connection between our second and first speaker that you may not know about. When Andrew Carnegie was writing his will and establishing the endowment for international peace that bears his name, he had a problem. He wasn't sure what they should do with the money after world peace had been achieved. That tells you something about the optimism of the early 20th century. It tells you something about the dilemmas of the fabulously wealthy who actually have to think about their legacy in a serious fashion. His will says that in the event of world peace, should any of his endowment remain, it should be used to solve the problem of health care. He didn't have a third choice. He was pretty confident that if world peace didn't make him a pauper, health care would. And what we're going to learn tonight is a little bit about how serious that possibility actually is. To introduce our guest speaker, I'd like to introduce you to a student, a member of the sophomore class, Brooke Sutherland. Brooke came to Washington Lee from Lawrence, Kansas, where she was the president of the Student Senate. She was captain of the tennis team, which is not that unusual, except that it was the men's tennis team. Brooke has been an outstanding student at Washington Lee, hopes to be a major in French and journalism, and I'd like to invite her to the podium to introduce our guest.
As debate over healthcare reform continues to rage in Congress, there could not be a timelier speaker to open the Johnson Lecture Series than Shannon Brownlee. Brownlee has made her career out of writing about medicine, both its benefits and encumbrances. She has written extensively about the faults of the U.S. healthcare system and the unnecessary costs and procedures commonly found in hospitals all across the country. Her work has been published in numerous magazines and newspapers, including New Scientist, The Washington Monthly, Newsweek, Epoch Times, The Atlantic Monthly, Christian Science Monitor, and The Washington Post. A senior research fellow and Bernard L. Schwartz Fellow at the New America Foundation, Brownlee has earned numerous awards for her writing, including the Association of Healthcare Journalist Award for Excellence, the Victor Cohn Prize for Excellence in Medical Science Reporting, and the National Association of Science Writers Science and Society Award. Her 2007 book, Overtreated, Why Too Much Medicine is Making Us Sicker and Poorer, was named the Best Economic Book of the Year by the New York Times. But more important than any award is what Brownlee can teach us about our own healthcare system. Reading an excerpt from Overtreated for my politics class, I was floored by her unique insight into the U.S. culture of medicine and economics. New York Times economic columnist David Leonhardt described her work as the best description of a huge economic problem that we know how to solve, but is so often misunderstood. A young girl, only 18 months old, goes into the hospital with second-degree burns, but becomes so dehydrated that the smallest dose of narcotics pushes her into cardiac arrest. A 37-year-old woman spends 24 years visiting the offices of various specialists who fail to diagnose a disease any self-respecting primary care physician would have caught in one visit. These are the issues that are facing us today as we attempt to improve our healthcare system. These are the issues we should be paying attention to. The title of Brownlee's talk tonight is After Reform: How We Can Transform Medicine, Improve the Nation's Health, and Avoid Going Broke. I hope you will join me in welcoming her as the inaugural speaker of the Johnson Lecture Series.
Thank you very much, Brooke. I need to switch my little gizmo on here. All right. Thank you all for being here. And I called it After Reform, but I could have called it How to Kill Healthcare Zombies. And but I wasn't sure everybody would come if I called it How to Kill Healthcare Zombies. But we'll get to healthcare zombies in a little bit. So why can't the United States fix its healthcare system? We have 47 million people who are uninsured, and the number is swelling. That's 1 in 6 under the age of 65. 2 million of those people are veterans, and they can't be cared for by a Veterans Administration hospital because they make over $25,000, or their health problems are not considered service related. Huge and unpayable bills have become a major reason for personal bankruptcies in this country. People who get into car accidents who are uninsured get less care than people who are insured, and they are more likely to die. Women who lack health insurance don't get regular pap smears to check for cervical cancer, one of the most effective things that we can do in terms of screening for cancer. Children who are uninsured go without routine vaccinations. Children with asthma don't get treated. And children die because their parents don't have health insurance. In 2007, a young boy, a 12-year-old, and my son was a 12-year-old at the time, so this really resonated. Diamante Driver was 12 years old, and he died in a Washington, D.C. hospital right around the corner from the White House. And he died from a brain infection that started with a rotten tooth. Diamante had a brother, and they both had bad teeth, and they had a single mother. And their mother was working 2 jobs, but she wasn't able to get health insurance at either of her jobs. So she was on Medicaid, but she couldn't find a dentist who would take the low Medicaid fees. And while she was looking for a dentist, she lost her Medicaid. And meanwhile, her children's teeth were getting worse and worse. Diamante didn't want to complain, so he didn't tell her how badly it hurt. He thought his brother's teeth were the bigger problem. And Diamante's teeth got worse and worse, and finally he got a brain infection, and he died in his mother's arms. And his care for his brain infection cost the hospital in Washington, D.C. $250,000. So a little boy died in his mother's arms because she couldn't pay for an $80 extraction. And his story is just one of the tragedies that could be told about the 20,000 Americans who die prematurely each year because they lack adequate access to health care. And this is why there is such a sense of urgency right now in Washington to pass some kind of health care reform, because it's a national tragedy when a child dies from something that could have been treated, and because it's a national disgrace when the richest country on the planet cannot seem to cover 47 million of its citizens. And this time around, it looks like we might actually have health care reform. And it's through no lack of trying to impede it. I mean, we've had accusations of government death panels, we've had accusations of rationing, illegal immigrants crowding emergency rooms, Planned Parenthood infiltrating the schools and teaching sex education to kindergartners. What are some of the other, government takeover of hospitals, and a guy named Joe Wilson calling the president a liar. And despite all of this, we might actually get health care reform. And it would mean that we will be on the verge of passing something that has been debated for nearly a century. We've been trying to get universal coverage in this country since World War I, starting with, whoever was the president at that time. We tried again during the Depression, the Truman administration, the Eisenhower administration, the Clinton administration, which foundered on a couple of characters named Harry and Louise, for those of us who remember those ads. And in effect, what people were made to fear was that if we covered everybody, we would have rationing. And while we feel sorry for the people who are uninsured, we want no part of a plan that involves us losing something that we think we need. So Barack Obama was in fact the 8th president to make a run at universal health care coverage, and it looks like it might happen. Now that's the good news. The bad news is that when the legislation passes, everybody's going to pat themselves on the back, they're going to wipe their hands off, and they're going to say, job well done, and we will have failed to accomplish an even more important task. And that other task, what we've been arguing about in all the town halls and up on the Hill, is not health care reform, it's health insurance reform. And what the task that we're not going to do, I think, is we're not going to get a grip on the spending. Because that requires delivery system reform, which is very different from health insurance reform. So this year, we will probably spend about $2.4 trillion on healthcare. Healthcare is one of 2 sectors of the economy that's actually adding jobs right now. Education is the other one. Healthcare is adding more jobs than education, I think. So $2.4 trillion, that's a lot of zeros. What is that compared to? It's 2/3 of the entire worldwide market for petroleum. We spend more on healthcare than we do on food. We spend more on healthcare than we do on defense. We spend more per capita on healthcare than the Chinese spend on everything. And if you look to the future, the Centers for Medicaid and Medicare Services predict that healthcare costs are going to hit about $4.1 trillion by 2016. That's more than 20% of GDP. And we are currently spending about $8,000 per citizen in this country to pay for health care. That's 2.5 times the median for any industrialized country. It's about $32,000 for the family of 4, and we're paying it through higher taxes, lower wages, and out of pocket. So even if your health insurance only costs what I think the average is up to now, $16,000, and if your employer pays part of it, you're actually paying $32,000 for that family of 4 because you're paying for a lot of health care through taxes. Private insurance only accounts for about half of the $2.4 trillion. Now that's more than most Americans spend on a mortgage. So it's enough to pay the interest on a small business loan. You could buy a new Lexus every year. You could send a kid to private college. And the real problem is that each year, the rise in health insurance premiums and the amount that we pay for health care is going up faster than the rest of the economy. And the money is not coming out of your employer's pocket if you're getting insured by your employer. It's coming out of your pocket. It's coming out of your pocket in the form of lower wages. So workers' wages, the average worker's wages are barely keeping up with inflation. And meanwhile, more and more money is being sucked into the health insurance industry. And you can almost think of the health insurance industry as this giant vacuum cleaner, and the health care industry is this giant vacuum cleaner, and the health insurance industry is the hose. It's through the thing through which the money flows. And that vacuum is basically hoovering up all the productivity in the rest of the economy. And I don't see how companies can keep feeding that vacuum. They can't do it in good times, much less in a period of recession. So their only choice is to drop health insurance, which they're doing in droves. It's really quite extraordinary what companies end up paying in health insurance, what it means. Howard Schultz is the CEO of Starbucks, and about 3 years ago he announced that he was spending more on health insurance than he was on coffee beans. And healthcare economist Uwe Reinhardt once said that General Motors was basically a health insurance company with a sideline in cars and SUVs. And that means that Starbucks is basically a health insurance company with a sideline in Frappuccinos. And if the Congressional Budget Office is right in its projections about how much we're going to spend on health care over the next 30 or 40 years, the entire United States will be one health insurance or health delivery system with the sidelines in weapons manufacturing and financial services. And these days, the financial services hasn't been doing so good. So you can't have an economy that's 50% healthcare. And something that can't happen won't happen. And you can't have companies seeing their insurance premiums going up twice as fast as their income growth. And so in 2007, 60% of companies offered health insurance to their employees. That's down from 69% in 2000. So that is one of their solutions, is to simply drop health insurance as one of the benefits that they pay. So the question is not, will we reform the delivery system and will we find a way to control costs in healthcare? The question is how. And in order to answer that question, we have to look at why our healthcare is so expensive. Is it because it's so great? It used to be that politicians said that. During the presidential campaign, there were a lot of politicians who were saying we have the best healthcare in the world. And a lot of Americans still think that we have the best healthcare in the world, but it's simply not the case. On every conceivable measure, the health of Americans, which is the product of healthcare, lags behind the health of citizens of other industrialized countries, starting with life expectancy. In 2001, U.S. life expectancy at birth was 77 years, which put us a few months ahead of Cyprus, Costa Rica, and Chile, and many years, not many, but a few years behind Canada, Japan, and Western Europe. We rank 28th in the world on infant mortality, behind Cuba, the Czech Republic, and the United Kingdom. These are countries that ought to be beating us at soccer, not healthcare. We are no less disabled by disease than citizens of most developed countries, and our medical care is, with few exceptions, no better at helping us survive specific diseases. In fact, a recent study of heart attack patients found that Canada did just as well as American patients, even though many Americans consider Canadian health care, where you often have to wait for certain elective procedures to be, we think that it's an inferior system. So the good news is that we've done a better job in curbing smoking. The bad news is our obesity epidemic is out of control. So why is our healthcare so expensive? If it's not really any better at producing health, which is the thing that a healthcare system is supposed to produce, one of the things it's supposed to produce, why is it so expensive? Well, conventional wisdom says that it's expensive because we don't ration care. We don't have to wait for that CT scan like you do in Canada. You don't have to wait for that elective surgery that you might have to in the United Kingdom. That's mine. I'm sorry. You can kill it. It's in the outside pocket on there you go. So, but when economists look at the 15 procedures that account for most of the waiting lines in other countries, those procedures and tests account for only about 3% of healthcare costs. So it is not, we don't have expensive care because we don't make people wait in lines. Sorry, make the person under the age of 30 fix the phone. So why is it expensive? If you ask a doctor, you'll get one answer. If you ask an economist, you'll get another answer. If you ask Republicans, you'll get 3 more answers. Ask Democrats. You may think that it's because of fraud or because of administrative waste, greedy overhead, greedy salaries in the insurance industry, or greedy pharmaceutical companies, demanding patients who ask for drugs and tests and procedures that they see advertised on television. And all of these things do contribute to the high cost of our health care. But there's one thing that hardly anybody wants to talk about. Well, actually, they want to talk about it more in the last few months. But for most of the debate, we have not really talked about one of the biggest single contributors to our ridiculously expensive national health care bill, and that is the money that we spend on unnecessary care. We spend about $700 billion a year on care that we don't need. That's 20 to 30 cents on every healthcare dollar. We pay for CT scans and MRIs that don't help doctors diagnose disease. We pay for unnecessary surgeries. We pay for drugs that offer only marginal benefit. We pay for days in the hospital that not only do nothing to improve the patient's health, but put them at risk of having an error or getting an infection in the hospital that might even kill them. Now, It's probably hard to believe for a lot of people that we spend that much on unnecessary care, because almost everything in our personal experience of the healthcare system says that far from getting too much care, we're not getting enough. I mean, when you go see your primary care doctor, you sit in the waiting room, then you get into the exam room and you take off your clothes and you wait some more wearing that little flimsy paper gown that never has a proper closure on it. And when your doctor finally breezes in, they have exactly 7 minutes to talk to you before they're giving you the bum's rush out the door. And when you try to get an appointment with a specialist, you have to wait. And when you try to fill a prescription, your insurer is fighting with you over whether or not they're going to pay for it. So far from perceiving that we get too much care, we have this perception that we're not getting enough. But this is the terrible paradox of our system. It is failing to deliver needed care to millions of people. We're hassled by the insurance companies at every turn, it seems, and yet we are giving people $700 billion worth of care that we don't need. So today I'm not going to talk about health insurance reform, but I'm happy to answer questions about it and about the current, sort of what the current bills are doing. What I want to do is focus on the delivery system side, on the incredibly wasteful, inefficient, and dysfunctional way in which we care for patients in this country for the most part. And I want to focus mostly on one aspect of that delivery system, its tendency to give people massive amounts of care they don't need. And all you have to do to find out about unnecessary care is to talk to providers, to physicians and to nurses, and sometimes to talk to patients and their families. And I'll give you an example. About a year ago, an AIDS patient died in New York City. He was 59 years old and he was bedbound, he was conscious, but he was too demented to direct his own care. He was in the end stage of the disease. And he was sent to a Manhattan hospital from a nursing home because he was having fever and weight loss, which is pretty typical. He was so thin that the EKG leads wouldn't stick to the skin on his chest. Now, he had no advanced directive and he had no next of kin, and he was incompetent to direct his own care, and so he was put on a ventilator. The state of New York prohibits doctors from withholding life-saving care from incapacitated patients if there are no surrogates to help them make a decision. So actually, that's not quite true. The law lets doctors decide in cases where the treatment is futile. Now, the treatment of AIDS has dramatically advanced, but it cannot keep a man who is in the final stages of this disease from dying. So he was put on a ventilator, and pretty predictably, he developed bed sores, which can be incredibly painful. It's very hard to make sure that a patient with lots of bed sores is not in a lot of pain. And this man died a few weeks later after costing taxpayers thousands and thousands of dollars. He was, in effect, treated to death. So overtreatment really matters to patients. They don't always know what to call it. They don't always know that their experience is really widespread, but it matters to patients. And if this man had family, it probably wouldn't matter to them. So the question is, how widespread is it, and how do we know that it happens, other than individual cases? Well, the best evidence comes from a group of researchers at Dartmouth, the Dartmouth Atlas Project, and they have looked at how patients are treated in different parts of the country. And so they look at Medicare because that's where the data are. It's very hard to get information out of the private insurance industry. So if you look at data, you can get a lot of information out of Medicare data, which are publicly available if you have the money. So they looked at how much Medicare spent per Medicare patient in different parts of the country, and they found that there was a more than twofold variation. So you spend about Medicare spends about $5,000 per beneficiary per year in places like Minneapolis and Portland, Oregon, and Southern Virginia, and $14,000 per beneficiary per year in places like Miami and Los Angeles. And in fact, there are individual hospitals in the US where Medicare is spending an absolute boatload of money per patient. And that means that private payers are spending a boatload too, because it's pretty clear that what happens in Medicare is often paralleled by what happens in the private to patients under the age of 65. So there are these hot spots of spending. They are Southern California, Miami, downstate New York, Long Island, Chicago, all of New Jersey, a lot of Texas, Boston, Washington, D.C., Northern Virginia. And we know a few things about what is not driving that spending in these places. It doesn't correlate with how sick patients are, even though that's what the administrators of hospitals will tell you. We give patients more stuff because our patients are sicker. And it isn't prices, even though prices are higher in places like Los Angeles and Boston. It is not prices that's driving what's happening. It is something that health policy people call utilization. How much care, how many services got delivered to an individual patient. So patients are basically getting more stuff done to them in Los Angeles and Texas and New Jersey. Now, that might not be a problem if it was producing better outcomes. If a heart attack patient goes in Los Angeles and comes out better because of that extra care than that heart attack patient in Portland, Oregon. But in fact, we know that it is not producing better outcomes. And I'll give you an example. If you look at how much Medicare does spend on the average heart attack patient, it varies by about 30% from place to place. So if you have your heart attack in, say, Portland, Oregon, you cost Medicare about $23,000 over the course of the year, from the moment you have your heart attack over the next year. If you have your heart attack in Los Angeles, it costs Medicare $30,000. The price that Medicare is paying is not that different in Los Angeles. That $7,000 went to more stuff. It didn't go to higher prices. It went to more tests, more drugs, more hospitalizations, more procedures, more endoscopes down your throat, more imaging, more CT scans. And it's really interesting. Many, many sophisticated audiences miss this. It is the amount of stuff. It is not the price. And what did that $7,000, that extra $7,000, buy that patient in Los Angeles? Did it buy them a better outcome? Did it buy them better care? No, in fact, if you have your heart attack in Los Angeles, you have a 2 to 6% higher mortality risk. More care is not just not better, it's worse in some situations. Here's another way we know that we're spending a huge amount of money on unnecessary care. You're 4 times more likely to undergo spinal fusion in Boise, Idaho than in Bangor, Maine. You're 5 times more likely to undergo a bypass in Lincoln, Nebraska than in St. Cloud, Minnesota, which isn't very far away. You're 3 times more likely to get a coronary stent put in. This is a little device that is used in patients with coronary artery disease, heart disease. You're 3 times more likely to get one of those if you live in Elyria, Ohio, than if you live in Cleveland, Ohio, which is rather interesting since Cleveland, Ohio is the home of the famous Cleveland Clinic, which is a famous heart clinic. You're more likely to get this procedure in Elyria. Now, why is that? Is it because people have more heart attacks in Elyria, Ohio, or more heart disease? No, it's because there's 2 cardiology practices in Elyria that have very, very aggressive cardiologists. They simply practice in a very different way than the physicians in Cleveland. And when you repeat this over and over and over, what we see is this $500 to $700 billion spent on unnecessary care that doesn't improve patient outcomes. Now, and just to reinforce what this really means to patients, and this often happens at the end of life. This is when the most intensive care generally happens for most of us. And so the examples I have are mostly for elderly patients or patients who are very sick and terminal. But a friend told me recently about dear friends of his family, and both the husband and the wife were in their 80s, and they were in declining health. And the wife was given a colonoscopy to look for early stage colon cancer. This is called a screening colonoscopy. She didn't have any symptoms. And it was looking for a disease, colon cancer, which grows very, very, very slowly. So here is a person who has all sorts of other things going on, and you're looking for a cancer that there is an incredibly small chance that it would even give her symptoms over her expected lifetime. So she's given this colonoscopy, and she has a perforation. The piece of equipment perforates her bowel, which is very serious, and she has to be hospitalized. She acquired an infection while she was in the hospital, which was very difficult to treat. She was there for weeks. And when she was finally ready to come home, she was still really sick. She was really weak. And her husband, who was in no great shape himself, was really worried that he wouldn't be able to take care of his wife. The day she was discharged from the hospital, her husband died. So this is the terrible paradox of our healthcare system. We fail to deliver needed care, and we deliver, at the same time, we deliver a mountain of care that patients don't need and doesn't benefit them, and sometimes even harms them. So once we move beyond health insurance reform, we're going to have to address this problem head on. It is costing us too much in wasted dollars and in wasted lives. It drives up costs. It's bad for us. It's sort of the Goldilocks principle. I've been thinking about a way to sort of define this. We know that too little care is bad for you. We also know that too much care is bad for you. We know that about 20,000 people die from too little care. About 30,000 Medicare recipients die each year prematurely from care they didn't need. So the Goldilocks principle would say too little care is bad for you, too much care is bad for you. What you really want is just the right amount. And an unnecessary care has to be part of our national discussion. It has to be a discussion about quality of care. It has to be part of the discussion about spending and about costs. But the question is now, why are these regions of the country that deliver more unnecessary care, why are they doing it? Well, the overarching reason is because it's profitable. The incentives in the payment system all drive towards more care, not towards better care. Now, do I mean that every doctor is sitting in their office rubbing their hands together saying, another patient, another sail on my boat? No. Most physicians are no more greedy, no more altruistic. Well, I think they actually are more altruistic than a lot of other professions. But they are certainly no more greedy than any other group of professionals. They're working within a broken system that incentivizes them and hospitals and everybody else to deliver more, not to deliver the right amount of care, the just right amount of care. And so that AIDS patient in New York, for example, who was on a ventilator, he got put on a ventilator in part because a patient on a ventilator is a valuable commodity. A ventilator-dependent patient, especially one who has to undergo a surgical incision that makes him on a ventilator for a long time. They put the ventilator, rather than down the throat, they put it right through the throat, through the neck. It's among the highest paying things that a hospital can do in terms of Medicare payment. In fact, I learned about a hospital in Los Angeles that was owned by a group of physicians, and Medicare pays on the basis of how long you're in the hospital. They pay a set rate. So there's a 30-day ventilator rate. And this hospital was taking patients from other hospitals and putting them on ventilators. And I talked to a nurse who, this makes doctors sound really bad, but this was just kind of a small group of bad guys. So this nurse who worked there, she was moonlighting there. She worked at UCLA and she was moonlighting at this hospital. And she went into the room of a patient one day, and they had this big monitor for the ventilator, and it was flatlining. And the patient was sitting there up in bed, and the ventilator had fallen out of her throat. And the nurse said, "Oh my God, she doesn't really need to be on a ventilator, does she?" And she went to another nurse and said, "Do I need to put what's going on? And why is she on a ventilator?" And the other nurse said, "Because she hasn't hit her 30-day yet. She doesn't need to be on a ventilator, but she hasn't hit the 30-day mark yet." So a ventilator patient is a very profitable patient. The nursing home, a patient who needs, once the patient is discharged from the hospital, that patient on a ventilator is also profitable for many nursing homes as well. Another factor that is driving unnecessary care is physician opinion. So the good citizens of Boise, Idaho, who are getting all those back surgeries, is not because there are more back injuries in Boise, but it's because, once again, there are two groups of surgeons in Boise who really believe in back surgery. Now, these guys are not greedy doctors. They simply, truly believe in back surgery, despite the fact that there is no really good evidence to show that the main procedure that they were doing, which is spinal fusion, is any better than far less invasive treatments. We really don't have the evidence that says that spinal fusion really works. And this is true for about 50% of what physicians do. Half of what physicians do has valid evidence to back it up, and the other half is based on theory or what physicians learned in medical school or what some eminent physician thinks is a really great thing to do. I mean, this is faith-based medicine, but you still get paid for it. We also know that another factor driving rates of unnecessary hospitalization and tests and doctor visits in those hotspots like Los Angeles and Manhattan is the capacity of the healthcare system. The supply of beds actually drives how often patients are hospitalized, not how often they need to be hospitalized, but the supply of the resources. And it's interesting, once again, with this AIDS patient, physicians in Manhattan will tell you that they have one of the highest rates of ventilator-associated death in the country because of the state law that says you can't withhold life-saving care from people. But the fact is that the law is the same all over the state, but the rate of people who die on a ventilator in upstate New York is very, very, very different. And one of the reasons is there are fewer ventilators per capita in upstate New York. So these regions where we see these very high rates of spending and utilization and high rates of overtreatment are often overendowed with medical resources. I mean, if you look at Los Angeles, it's hugely overbedded. It is carpeted with these little tiny hospitals. There are hospitals that are within, a mile, half a mile of each other. And the reason is purely historical. It was post-World War II. Physicians settled in Los Angeles. They opened their own hospitals. Los Angeles is also absolutely carpeted with physicians. It has the highest rate of specialists of any place in the country. Another paradox of healthcare, Los Angeles has it's very hard to get an appointment with a specialist. Even though it has more specialists that, you're practically tripping over the specialists, it's harder to get an appointment with specialists. So in New York State, there was something called the Berger Commission that recommended shutting down 7% of the state's hospital beds. And they could probably ship about a third of the physicians to Africa and improve the relative health of both countries, of both continents, while they're at it. Manhattan has a heck of a lot of specialists as well, and not enough primary care physicians. We are also looking at widespread duplication of medical technology. So since the demise of managed care in the 1990s, hospitals have been engaged in what a lot of healthcare policy people called a healthcare arms race or a health technology arms race, which has effectively been a buying spree that would put a lot of military dictators in the third world to shame. I mean, every little hospital in this country, every 200-bed hospital in this country wants to have its own 64-slice CT scanner. This is a very cool device. It is able to take a picture of a beating heart and create a three-dimensional color image of it. Cardiologists love it. Radiologists don't care. They don't need 3D images, but cardiologists love it. Now, why are hospitals buying this thing? Because everybody's seen the picture of the heart in the ads that GE was running on TV, and it's very cool. Hospitals can advertise to patients and say, we have the latest technology, come to our hospital. But the other reason that they want this technology is that they want to bring in cardiologists to come practice at their hospital, because cardiology is way more profitable than pneumonia. So hospitals are on this buying spree. They're buying Da Vinci surgical robots, even though there's no evidence that a Da Vinci surgical robot will improve the outcome of your prostate surgery. They are buying MRI machines. You have a patient with a headache? MRI. You got a patient with a back pain? MRI. MRIs are very profitable. PET scanners. Now that Medicare pays for PET scans for patients who might or might not have Alzheimer's, everybody's got their PET scanner paid for. All these hospitals have been able to pay for their PET scanners and are now making a profit on them. Never mind that 1 in 4 patients who are PET scanned will get a false positive. Imagine being told you have Alzheimer's when you don't. So these, and in fact, these hospitals always, I mean, no matter how expensive this equipment is, and it's multi-million-dollar equipment, hospitals find a way to recoup the investment. I got an email from a doctor who was fired from his job as a hospitalist, which is a kind of primary care doctor who's hired by the hospital to do two things. One, try to sort of manage the care of complex patients, and two, get patients out of the hospital when insurance is no longer paying. So this guy was fired from his job because he wasn't ordering enough tests. And that is exactly what they told him. They said, there's no problem with your doctoring. We have no problem with the quality of your care. You simply don't order enough tests. And this is just one anecdote, but it fits in with many, many stories that I've been hearing over the last 2 years since I published my book. I hear it from radiologists who are reprimanded because they tell other physicians that the images that the physician is ordering are unnecessary. The surgeon in an academic center who was told that he wasn't doing enough of the high-end surgery. There were two ways to repair an aortic aneurysm, and he wasn't doing the one that was most profitable for the hospital. And then there's this hospital in Santa Clara, California, that took all of its emergency physicians off of salary and told them that they had to bill on a fee-for-service basis, which means that every patient who comes in, if you order a test, you have to bill the insurer. If you perform a procedure, you put in a chest tube, you put in anything, you have to bill for every single procedure. So now what the nurses do is they go out in the waiting room and they do a wallet biopsy. They find out who's insured and who isn't, and people who are not insured are sent down the street to the county hospital. And what's really amazing is this is a not-for-profit hospital that is run by a religious order, the Sisters of No Mercy. And then there's the press. My colleagues in the press have behaved like what some of us have been calling the tiny brain chihuahuas, which is we've been yapping at all the medical outrage du jour. Hospitals that dump uninsured patients, oh my goodness. HMO doctors that won't prescribe Vioxx, so that was a big scandal until everybody figured out that Vioxx was actually killing people. Insurance companies that won't cover bone marrow transplants for breast cancer patients. It turned out that that was killing patients too. I mean, we are filled with a huge amount of outrage and not very much wisdom. So, and the insurance industry is still the press's favorite target. And I have to tell you that that's part of the blame does rest with the insurance industry. Does anybody know the name William McGuire? William McGuire was the CEO of one of the biggest insurance companies. I'm not sure if it was Aetna or the other big one. And he was making about nearly $1 billion in total compensation by the time he left. And he left with a big golden parachute. And he almost went to Club Fed because of tax evasion. So when insurance company executives have these gigantic salaries, and they then are doing things like dumping people. As soon as you get sick, you lose your health insurance, and refusing to insure people who have pre-existing conditions, and saying no to all those MRIs that the hospital is telling you that you really need, and squeezing the life out of primary care physicians. It's very easy for the press to go after the insurance industry. But it's not clear to me that squeezing the insurance industry would really do anything about our soaring healthcare costs. I mean, right now it's very popular to say that if we could cut the administrative waste in healthcare in half, we would save a whole lot of money. Well, let's just kind of take that apart for a minute. The insurance industry accounts for about 46% of that $2.4 trillion. And if its overhead is 30%, a reasonable estimate is that you could cut its overhead to 15%, which is what France's private insurance is. So how much money would you save? $151 billion. Not exactly going to bring us in line with the rest of the industrialized world. So, and yet it's so easy to demonize the insurance industry. In 2007, there was this Harris poll that found that only about 7% of Americans think that insurance companies are honest and trustworthy, which means 93% of Americans don't trust their health insurance company. I mean, even journalists come out ahead of that. And doctors, on the other hand, get thumbs up from about 85% of the public. And these are not aberrations. These numbers have been consistent for the last 5 years, and it's actually very difficult to get this kind of agreement on anything in the American citizens. I mean, only 79% of Americans think that the Earth revolves around the sun. So basically, we don't trust insurers. We do trust our doctors. We don't trust journalists. I'm not sure I trust journalists. We don't trust the drug industry. We're kind of iffy on the hospital industry. And so when the doctor says you need an MRI, who are you going to trust? Your insurance company that says no, or your physician? So what are we going to do? We have a health insurance industry that's basically morbidly obese. We need to get it to slim down. Well, step number one is we need to agree on what the end game should look like, what the delivery system really should look like. And we've actually known the answer to that question for quite a while, in fact, since the 1980s. And the answer is organized multi-specialty group practices. That's a sort of fancy name for places like the Mayo Clinic, for Kaiser Permanente, the Carillion Clinic in Roanoke, for those of you who go to Roanoke for some of your care. And what these are is they're groups of physicians who are generally salaried and who work under the same financial umbrella as a hospital, one or more hospitals. And what they do is they put a premium on primary care. Their physicians communicate with one another. They try to give you the right care, not too much care, not too little care. And so the end game now is still the same as it was in the 1980s. We need more of these group practices. We need doctors to coordinate the care of the chronically ill. We need lower utilization, fewer hospitalization in many, many cases. We need less useless, expensive, and potentially dangerous care. So what are the steps that we need to take to get from here to there? Because most of the system is disorganized. How many people have spent any time in the hospital themselves or had a loved one who's been in the hospital? So that's a lot. So tell me, did it seem like a seamless operation to anyone? Did you get a straight answer from everybody about what was going on? Did one hand know what the other hand was doing? I mean, we track, I think Walmart probably tracks a box of nails better than we track patients in hospitals. I have a friend whose wife went in for breast cancer surgery, and she had to have a mastectomy. And when she came out of the surgery, nobody knew where she was. And he wasn't there when she came out after her mastectomy because the hospital didn't know where she was. Which recovery room was his wife in? So there are a number of steps to get from disorganized, chaotic care that overuses a lot of things and doesn't deliver things you actually need to organized care that gives you what you do need, gives you just the right care. And to get there, we have to start by killing off healthcare zombies. There's these ideas about healthcare reform and cost control that don't work, but they won't die. So zombie number one, controlling the price of medical services will bring down spending. So most of healthcare is paid for on a fee-for-service basis. Each office visit is reimbursed. Each test is reimbursed. Each procedure is reimbursed. Each day in the hospital is reimbursed. And health insurers and Medicare have tried to control spending by extracting price concessions out of physicians and hospital, and it's not working very well. It's sort of like playing a game of whack-a-mole. First you squeeze prices and spending goes down for a little while, and then spending goes up again because physicians and hospitals are incredibly clever at figuring out ways to increase the volume of services. So one of the problems that Medicare has right now is with something called ancillary services. They have squeezed their reimbursement rates to physicians so hard that physicians are turning to other ways to make up their lost money. And what they're doing is they're buying their own MRI machines. They're giving extra tests. They're doing a whole series of things that are called ancillary services. I mean, it's sort of like any piece worker does this. This was pointed out to me by Arnold Relman, who was a former editor of the New England Journal of Medicine, and he said, medicine is the ultimate piecework. So if you're a shirt maker in a factory and you get paid $10 a day for making 10 shirts, and your employer says, I'm only going to pay you 75 cents per shirt, what do? You make an extra shirt to make up for lost income. And so trying to extract price concessions has become counterproductive. And it's really counterproductive when you do it to these places, these organized group practices that are doing a better job for less. So you squeeze everybody across the board and you punish the good, and it ends up that you don't really change the behavior of the bad. So healthcare zombie number two, patient demand is driving healthcare costs, And if we could just get patients to quit demanding so much unnecessary care, we would reduce spending. So if you've subscribed to this healthcare zombie, you think that one of the solutions is something called health savings account or consumer-driven healthcare. My husband and I are both self-employed, and we actually have one of these health savings accounts, and it works for us because we're very, very healthy. And so it's, in effect, we're basically insured against catastrophic illness, but we pay out of pocket for most sort of ordinary care. Well, this kind of can work for some people, but for the chronically ill, it really doesn't work. And the chronically ill are the biggest spenders. They're not the biggest spenders. The chronically ill, there's something called the 80-20 rule in healthcare. 20% of patients account for 80% of costs. Now, the numbers kind of switch back and forth, but you get the idea. A small percentage of patients account for 80% of what we spend. And the chronically ill are that 20%. People with diabetes, people with heart disease, people with kidney disease, with pulmonary disease. And these people, where we spend the money on the chronically ill is when they are hospitalized. And when you are in the hospital, it is very, very hard to be a prudent consumer of healthcare. So if you were a prudent consumer of healthcare, you would be asking the price of every single thing that happens to you. And that's not what happens when people are in the hospital. If you are a prudent consumer of healthcare, you say, why do I really need that MRI? Do I really need to have that Foley catheter put in so that I can urinate? Do I really need to have that drug? That's not going to happen when people are hospitalized. Now, it is true that patients do demand a fair amount of unnecessary stuff. I mean, I've been in the emergency room when a mother came in with a child who had fallen off the couch and bumped his head on the carpet, neurologically absolutely fine, and the mother says, I know he needs a head CT. And it's easier for the emergency physician to just say, okay, fine, go get a head CT. It's easier than sitting there and explaining that a head CT has a huge amount of radiation, that there's absolutely no reason to do it. It's just easier to send the kid to the head CT. So we do demand a great deal. In fact, I talked to a doctor recently who said to me that he had a 12-year-old boy come in and say he was having chest pains and he wanted a cardiac catheterization. I think this kid has been watching too much TV. Oh, goodness. But so these high deductible plans can nibble around the edges, but they're really not going to make a really big difference. And they could, in fact, harm people because of the kinds of choices that patients make. They don't make rational choices based on money. The New York Times ran a story a few weeks ago about people who were scrimping by not filling their prescriptions. Now for some things, that's probably not such a bad thing because there's an enormous amount of overprescribing of really marginal drugs. But when a diabetic decides to cut down on his blood pressure medication because it's too expensive, that's not a good thing. And when an asthmatic decides not to use it or to use his inhaler every other day, that's not a good thing either. And it can lead to more hospitalizations. So in the end, it ends up spending more money, not less. So demanding patients is really not the reason that we're spending $700 billion a year on unnecessary care. And trying to turn the chronically ill into prudent healthcare consumers is really not going to work. Healthcare zombie number 3, prevention is going to save us a lot of money. If only we could keep people from getting sick. Now the corollary, that's primary prevention. So get people to stop smoking. That will prevent about 200,000 deaths from lung cancer. If nobody smoked in this country, we would immediately see lung cancer deaths drop. But the corollary to this idea is let's screen people for diseases like cancer and heart disease before they have symptoms, and then we'll save money because we won't be treating them further down the road. Well, first of all, screening does not lower mortality for a great many things that we screen people a lot for a lot of. So PSA testing, for example, men of a certain age get a prostate-specific antigen test. It's supposed to catch prostate cancer early. There's not a lot of evidence that it's reducing mortality. There's a whole lot of evidence that it's leading to men being incontinent or impotent or both, because the major treatment is surgical removal of the prostate. So second, the prevention theory would work if it meant that people would stay healthy into their 90s, play tennis in the morning, have lunch, and die. But that's not what happens. What happens is we get old and we get frail, and we still die of chronic diseases, and we are demented. The older you are, the greater the chances that you will be demented. So if we really wanted to save money, what we ought to do is tell everybody to smoke, and then we would all die young, and then we wouldn't have to pay Social Security, and we would have a much shorter period of time that Medicare was paying for us. But this is what's insane about this idea of prevention to save money. I mean, you don't buy food in the grocery store to save money. You buy food in the grocery store to live. And you buy good food in the grocery store to live well. And so the reason to prevent disease is not to save money. It's to make our lives better and longer. So healthcare zombie number 4, rationing is the only answer. And that, I think, depends on what you mean by rationing. If you mean getting rid of tests that are done because it's profitable for the hospital, and office visits that are scheduled because it brings in income for the physician, and surgeries that are done in the face of complete absence of evidence that they're actually effective, well then I think rationing is a good idea. But mostly we think of rationing as denying people care that could help them have better lives or live longer, and they're denied the care because it's too expensive or they're too old. And I think that we are about $700 billion away from needing to ration needed effective care. We are a long ways from needing to curb our spending by rationing care that people really need. So what can we do that's going to work? I think we need to use carrots and sticks. First, the stick. We need to go after the parts of the country that are spending the most and delivering the worst care. Places like Los Angeles and Miami and McAllen, Texas, and all of New Jersey. I think Medicare needs to start penalizing these hospitals in these regions. It doesn't have to be a very big stick. It doesn't have to be a really big penalty. It really mostly has to tell the bond market that healthcare is not the bottomless money pit, and that these hospitals that are going to the bond market to expand capacity can't keep doing it. The bond market is not going to lend them money. Number 2, we need to start measuring outcomes. We need to look at Hospital A and Hospital B and see how their patients fare. Now that can be done to a certain extent with Medicare recipients. It's a lot harder for patients with private insurance because the data aren't available. But it's possible. Number 3, we need to pay for care in a very different way. One of the reasons that UCLA is spending $7,000 more on that heart attack patient has to do with the way we pay for health care. It's sort of a central tenet of economics. We're getting what we pay for, and we pay for them to do more, not to do better. And I said that the vast majority of doctors are getting paid through fee-for-service, not managed care, but fee-for-service, which is how we pay car mechanics. And we need to start paying them in a very, very different way. And so these organized group practices, some of them actually have a prepaid method where you pay each patient, each client, customer, pays a set amount per year to be cared for. And if you cost less than that amount, then the providers get to keep the money. And if you cost more, the providers lose money. So that gives them a really big incentive to keep you as healthy as possible. And our payment system pays whether or not doctors know whether something actually works or not. It's sort of like shoot first, ask questions later. We pay first, and then we say, gee, does that really work? So we've been paying for back fusion surgery for 30 years now, 40 years. And we have never done the science that's necessary to find out whether it really works, which leads to solution number 4. We need a comparative effectiveness institute, or what I call a Manhattan Project for medical evidence. We need to have it be, a lot of it needs to be federally funded because doctors and patients need to know what works, what doesn't work, and for which patients. And that's going to cost a lot. It's about $4 billion a year is what the estimate is. And Congress needs to step up the pace to pass this legislation because if we don't move quickly, the pharmaceutical and device industries are going to do a very good job of convincing the American people that this kind of research is really just a form of rationing. And then we're sunk. And finally, number 5, I think we need to have a very, very different way for patients to make decisions about whether or not they want elective surgeries. So all those back surgery patients in Boise, Idaho, and those cardiac catheterization patients in Elyria, Ohio, needed to have better information to be able to make the decision about whether or not they wanted that care. And what we need is a democratization of the relationship between physician and patient. And that's a really tall order. But it represents a real opportunity to not only reduce costs, but to truly improve care and to make sure that patients get care that they really want, to get elective surgeries that they really want in particular. Because in many, many cases, patients really do not understand what they're getting into. I'll give you an example. A friend of mine who is a physician, he's a hospitalist, told me this story. His name is Peter Kibbe, and he told me about a frail elderly man that he was caring for, that he'd been caring for repeatedly because this man had everything was going wrong. He had kidney disease, he had heart disease, he had liver failure. He didn't have liver failure, but he had a lot of things going on. He had diabetes, and he had these crises that would land him in the hospital. So he was in the hospital yet again, and Peter was examining him, and the man clutched his chest and began screaming. And he looked at Peter and said, "Stop it, stop it." And he was clearly in terrible pain. And this happened a couple of times over the course of the next half an hour. And what was going on is that the man had an implantable cardiac defibrillator. This is a little device. It's a little bit smaller than my cell phone. And it's implanted into the heart, and it effectively does to the heart what those external paddles on ER do. You know, they shock the heart into going back into a regular rhythm. And this little device had shocked this man because his heart was not beating regularly. But he was so demented he could not remember that he had had it put in a few months before. So this is a guy who has the life expectancy of a fruit fly, and he has had one of these very, very expensive devices put in. It's about $90,000. Not just the device, but the actual procedure, and then sort of follow-up care for this device. And in some people, this device really makes a difference in life expectancy. If you have something called VTAC, ventricular tachycardia, or ventricular tachycardia, and you're in your 50s or 60s, this thing can really prevent you from having a really early death. But in someone who has everything going wrong all at the same time, the chances that it would have increased his lifespan were very, very slim. And it certainly made the last few days of his life really miserable because he was shocked several more times before he died. Now, did his family, who consented to this device being put in, every good system in this country starts with good primary care, the person who knows you as a whole human being, who can help you decide what you want and what you don't want, who can guide you, who keeps track of everything, that is supposed to keep track of everything that's happening to you. Even if you go out to multiple specialists, that primary care is the one who needs to watch over your care. So this, again, is the terrible paradox of American medicine. We're not delivering needed care, and at the same time we're giving care, a lot of care that patients don't need, and that they probably would not want, a lot of it, if they really understood what the potential downside was. And the very regions that are delivering the most unnecessary care, ironically, are the ones that are also not getting good outcomes, and they're the ones that are not giving people needed care. And the very regions of the country and the very individual providers in the country are the ones who are giving just the right amount of care. They're organized. They've figured out that medicine should be practiced as a team sport. So I want to leave you with the good news and the bad news and a prediction. The bad news is we're spending 500 to 700 billion. The good news is we're spending 500 to 700 billion. And that's an extraordinary opportunity. That money is a real opportunity. If we can find ways to recapture it, it's more than enough to cover the uninsured. It's enough to hire nurses and case managers to take care of the chronically ill, to coordinate their complicated care. It's enough to pay for electronic medical records and gather the data to help physicians know how well they're doing and to know what works and what doesn't. So here's the prediction. We're going to pass some kind of healthcare reform, and it's going to cover more people. And if it doesn't have a public option, it's going to be a huge bonus for the insurance industry. And if it does have a public option, taxes are going to need to go up unless we find a way to control spending. And none of it is going to be easy. It certainly hasn't been easy to get to this point, and it's not going to be easy to transform a $2.4 trillion industry. It's like turning the QE2 with a school of tuna fish. And one of the critical factors in pushing this giant behemoth system in the right direction is going to require changing patients' minds. So the press, I think, has a leading role to play here, if we could just stop yapping. And physicians have a part to play, along with payers and employers. We all have to quit leading patients to believe that something is new, it must be improved, and that more is always better. And as patients, we really have to begin to understand that when it comes to medicine, sometimes less really is more. Thank you. Happy to answer questions?